Good evening, everyone. How's the volume? Is it loud enough for you? Good. In the back? Okay, also? Wonderful. Good. Welcome to La Jolla Institute for Immunology. I am Erica Ollmann Saphire, President and CEO, and one of the research faculty here, and I am delighted to have you join us for another installment of our Life Without Disease lecture series. Your presence here this evening reflects something powerful. This community's shared commitment to advancing discovery, strengthening scientific collaboration, and accelerating progress toward a future of life without disease. While our shared goals are ambitious, moments like this remind us that meaningful breakthroughs happen when community comes together around a common purpose. So for those who may be visiting LGI for the first time tonight, let me briefly share what drives our work. For more than 35 years, the La Jolla Institute for Immunology has pursued a singular mission: to understand the immune system so deeply that we can harness it to prevent, treat, and ultimately cure human disease. Your immune system touches nearly every organ and controls or sometimes causes nearly every human disease. So understanding that immune system and how we can harness its power and direct its precision is the best tool we have for health and longevity. From cancer to chronic infection, from autoimmune disease to emerging viruses, our scientists explore the most fundamental questions in immunology, guided by the belief that deeper knowledge today will lead to life-saving solutions tomorrow. Today's discussion is called The Pandemic We Didn't See, because while the world has largely moved on from COVID as a crisis moment, the virus, and more importantly, its consequences, are still very much with us. So step back in time. Early in the pandemic, LGI was the firehouse in the fire. We became one of the world's leading centers studying how the immune system recognizes and fights SARS-CoV-2. Our scientists provided some of the world's leading studies. Let me get that slide up there. The first studies examining how your immune system would fight SARS-CoV-2. The first detailed analyses of immune responses to the virus. We discovered evidence of pre-existing coronavirus immunity in some individuals. We coordinated international antibody research, and we generated knowledge that helped guide vaccine discovery itself. These are just some of the papers we published in the very few first months of that pandemic. Now, step forward to the present day. As the pandemic evolved, the Institute has continued to build on that work, turning increasing attention to what happens after the acute infection, the long-term effects of the virus on the immune system and on human health. For many people, the story did not end with recovery, and it sure didn't end when the 24-hour news cycle ended. Instead, it shifted into something that is harder to measure and too often deeply debilitating: long COVID and other post-viral diseases. It's especially fitting that we're having this conversation now because March is Long COVID Awareness Month. So tonight, we're not here to relitigate lockdowns or early pandemic decisions. We're here to ask a different set of questions. What did we miss? What did we misunderstand in real time? And what have we learned from COVID about the virus itself and about how modern health systems respond to long-term invisible disease? I am joined tonight by an exceptional panel who approach this topic from different angles: clinical medicine, immunology, and science journalism. So come on up and I will introduce you. The first panelist I would like to introduce is Dr. Pam Taub, a cardiologist and professor at the UC San Diego School of Medicine. Pam is an internationally recognized expert in preventative cardiology and cardiometabolic disease. with a classical and research focus on how lifestyle, technology, and novel therapies can improve long-term cardiovascular health. In her medical practice, she's also treating patients who are living with long COVID. And she brings a frontline perspective to the virus's lasting cardiovascular effects. Additionally, Pam is the founding director of the Step Family Foundation Cardiovascular Rehabilitation and Wellness Center, where she has helped develop innovative programs that support patients recovering from heart disease while advancing prevention and long-term wellness. She is a widely published physician scientist and federally funded researcher. Her work explores how behavioral, technological, and pharmacologic strategies can improve cardiometabolic outcomes and reduce cardiovascular risk. Please join me in welcoming Dr. Pam Taub. Our next panelist is Dr. Sonia Sharma, an associate professor here at the La Jolla Institute for Immunology, where she also directs the Center for Sex-Based Differences in the Immune System. She is a Harvard-trained immunologist. She is widely recognized as a leader in translational immune metabolism. That's an emerging field that explores how immune cell behavior is shaped by molecular signals, metabolic processes, and genetic circuitry. Her work spans inflammation, infection, autoimmunity, and neurodegeneration, with discoveries published in many of the world's leading scientific journals. Today, Sonia is advancing one of the most overlooked frontiers in biomedical research, understanding how biological sex shapes immune function, shapes disease progression, and should shape therapeutic response. Through her studies ranging from COVID-19 to Alzheimer's disease to cardiovascular health, her lab is helping reveal why men and women can experience disease and respond to treatment differently. So please join me in welcoming Dr. Sharma. And our final panelist is Jason Gale, senior editor and biosecurity correspondent at Bloomberg News, and the author of the new book, After COVID, The Health Impacts That Will Last Generations. He is an award-winning journalist. He has spent years reporting on global health, infectious disease, and the science shaping pandemic preparedness. Drawing on an extensive frontline reporting and interviews with scientists, clinicians, and patients around the world, his work examines not only how the COVID-19 crisis unfolded, but also the lasting health consequences that continue to shape societies and health systems today. In his book, After COVID, he brings that reporting together to explore the pandemic's enduring legacy, from long COVID and chronic illness to the broader lessons for how we respond to future global health threats. Please join me in welcoming Jason Gale. So thank you all for being here and for sharing your expertise with us tonight. So together, our panelists' perspectives from science, medicine, and journalism will help us explore some of what we know and some of what we don't know. So let's begin our conversation. So the first question for all of you, really, let's zoom out before we zoom in. So let's start with a deceptively simple question, one that people answer very differently depending on their perspective and where they sit. Is the pandemic over? And depending on your definition, whether it's virological, immunological, clinical, societal, what does over actually mean?
Well, we know that in May 2023, the World Health Organization declared the emergency phase of the pandemic over. But we know in March 2026, SARS-CoV-2 virus is still circulating. It's still causing illness. It's still causing deaths here in the US. Each month, there are still COVID deaths. And it's still causing long-term complications. So from that perspective, the pandemic isn't over. And certainly for the people who are living with long COVID, many still live in fear of reinfection, and so are very concerned about how society has largely moved on and left them behind. So there is that aspect as well.
I agree with Jason. I think the acute phase of the pandemic is over, but what we're now left with is the chronic phase. There's many people that are suffering from sequela of COVID, which we're now calling long COVID, and these patients are having substantial issues accessing the right health care. People are blowing off their symptoms as being more psychological, and not really addressing these long-term needs that these patients need.
Agreed. I mean, the emergency seems to be over, doesn't it? But that doesn't mean that the virus is gone. The virus is still circulating globally. Yes, most folks are vaccinated, severe infections are lower, we don't have the burden on the healthcare system acutely, but that virus is still there. And it's actually adapted, it's actually mutated in such a way that some of the dominant variants of that virus, such as Omicron, which was very prevalent in California, actually don't cause a lot of acute symptomology in the short term, but in the long term are being associated with long COVID-like symptoms.
I think not so many people appreciated the beginning of the pandemic. You wouldn't just get infected and get better and be done with it. There are people now that are still millions of people that are not themselves and they can't work and they're exhausted and their brains aren't functioning like they were. So from that lens, I mean, what else did we misunderstand most in real time from the beginning of the pandemic?
I feel like one of the things that we misunderstood, I guess there's 2 points. The first, at least in my mind, scientifically, I really thought it was going to be black and white. Pandemic, virus, pandemic over, no virus. And it's just, I thought there was going to be an end point and that it would be over. And that's not the case for the reasons that we all talked about, in the last discussion. That's number one. And that's been an adjustment. Number two, I would say, we also maybe misunderstood how we need to communicate with our community, with our public as scientists. I'm sure politicians might say the same thing, and how we communicate this kind of evolving understanding. And I feel like anybody who's maybe a scientist or knows a scientist, maybe is a relative, understands that process. Like, oh, it's this today, but oh no, we learned something and it's different. And maybe we didn't realize that in order to maintain public trust and to communicate effectively, we maybe had to communicate that we didn't have all the answers or that they would change.
Yeah, early in the pandemic, there was an assumption that there were two outcomes of a SARS-CoV-2 infection: survival or death. And it wasn't until patients articulated this other outcome, which was debilitating, often long-term complications. So we have to thank them for raising what was going on to public attention. But when we look back in history, we've always seen post-acute infectious syndromes, polio, there's post-polio, Ebola. We know Epstein-Barr virus, mononucleosis has long been known to leave behind additional disease, increased cancer incidence, now multiple sclerosis. So we were a bit naive to assume that there wouldn't be consequences of a novel virus that causes a new disease, creating additional outcome.
I think the other aspect of how we dealt with it as a medical community and a scientific community, I think there was also an incredible arrogance. And I think what COVID has really done has made us humble and really teach us that we don't understand immunology. I mean, I really commend all the scientists at La Jolla Institute of Immunology, because I think the immune system is one of the most complicated systems there. And we've just really had a simplistic view, like you get an infection, you're recover. But COVID really humbled us and taught us there's things like viral persistence, persistent autoantibodies, all these things where an acute infection can wreak havoc on your life for a long time. And all of these syndromes that Jason was mentioning, like EBV, mononucleosis, they did leave a little bit of an imprint, but it was in such a small minority of the population that it didn't get the attention it deserved in terms of the research. And we missed an opportunity to learn from some of these diseases until we had this huge pandemic that impacted a large number of the population. So I think from just a scientific perspective, I think it's made us really understand all the things that we don't know, and we're still struggling with it. So I'm a clinical trialist. I'm trying to do clinical trials, but my clinical trials are limited because we don't really have fundamental mechanistic understanding of what this virus has done. We're just starting to crack the surface.
So that's a really good point, Pam, that the mechanistic point. And I think that gets lost in the words that we use. So we use this umbrella term long COVID, but is it one thing or is it many things? And if it's many things, what does it tell us about the mechanism, how we diagnose it, how we treat it? What is actually happening in our bodies? What do we know versus what we're assuming?
So I will tell you clinically, I've made this statement many times at many meetings. So in the late 1800s, Sir William Osler, the founder of modern medicine, said, "To know medicine is to know syphilis." And what he was referring to was a very, very complex disease that impacted so many different organs. And it was very difficult to figure out what is this disease? What is it doing? And then in the 1980s, we changed it to know AIDS and HIV is to know medicine because it impacted so many different organs. And in 2026, to know medicine is to know long COVID, because you see a patient with long COVID, they're the most complicated patient you'll ever see. They'll tell you, I have numbness in my fingers and toes. I have fatigue. I can't even brush my teeth. When I stand up, my heart rate goes fast. I'm short of breath. I mean, the list of complaints is so extensive. I mean, these are the most difficult and challenging patients to take care of.
So, Sonia, let me ask you a question. One of the things that keeps coming up over and over again in the scientific studies, the clinical studies, are these terms immune dysregulation and autoimmunity. Can you explain to us what immune dysregulation is, what autoimmunity really means? And then I'm going to ask you more about that mechanism.
Absolutely. So, our immune system is our friend. It is designed to protect us against foes. What are those foes? Bacteria, viruses, and cancers. And when the immune system is working perfectly, it's off. It's not when there's no pathogenic virus or bacteria or cancer, the immune system's sleeping off, no problem. When that pathogenic threat is there, springs into action, gets rid of the pathogen, and then goes back to sleep. Immune dysregulation, either it could be immunosuppression, where the immune system didn't wake up when it needed to fight off the bacteria or virus or cancer. And we know what can happen then. But it could also mean that the immune system did everything right, but then it didn't go back to sleep, or it woke up at the wrong time. That's autoimmune disease. Or not going back to sleep, that's what we may call chronic inflammation. And that's what immunologists and I think clinicians also mean when they say immune dysregulation.
So I'm such a fan of your research. I can listen to you talk about it all day long, but on a bite-sized level, like how do you measure this? What are the immune markers?
Okay, that's a great question. The easiest way to measure immune markers is a blood sample. Right, because invasive techniques going into the immune system is actually a different landscape almost in every different organ, as Erica mentioned in her opening talk. But that's difficult to look at. We can't biopsy the brain or biopsy the heart. That's not something that can be routinely done. But one way we can is your immune system lives in your blood. And so doing a blood sample, we can measure immune proteins. These are proteins, for example, called complement, or immune cytokines. Cytokines are proteins that enable the immune system to talk to each other across long distances in the body. Pro-inflammatory molecules like IL-6. These proteins, peptides, even small metabolites that are active and indicative of a woken up immune system can be measured in the blood.
So Pam, let me ask you a little bit about that cardiovascular system. One of the scariest things from reading Jason's book this week has been the myocarditis, the pericarditis, the people in their early 50s who just dropped dead from some of these infections. Those cardiovascular events in the country spiked well beyond the infection wave. So there's something happening right away, and there's something happening that's lasting. How strong in the case is the case that what Sonia's talking about, the immune dysregulation, rather than just inflammation, played a role in that?
A huge part. What we're learning is a lot of cardiovascular disease, even a basic heart attack. So if you look at a coronary plaque, which is the blockages that people get in their artery, well, what causes that plaque to rupture and cause a heart attack or stroke? Well, it's cells of the immune system. Those cells are coming into that plaque and making that plaque become unstable. So the immune system is intricately tied to the cardiovascular system. I think myocarditis, pericarditis, it's kind of the extreme example of how that link is there. But just with everything in cardiovascular disease, it's very much tied to the immune system. And I think that appreciation isn't there. And one of the things that COVID has done is really helped the cardiologists understand that connection a little bit better. So it's very, very important. And we're still not understanding what is causing that immune system to, as Sonia eloquently stated, to wake up or to shut down at the wrong times. Because when that happens in the cardiovascular system, we're seeing heart attacks and strokes and inflammatory diseases like myocarditis.
So we're talking about the immune system waking up. What about people waking up? So Jason, from your perspective, covering the pandemic for Bloomberg put you in a really rare and special position. You were watching the science, the data, and the politics all collide in real time and across the world. From what you saw and from what you unpacked in that book, why was humanity so slow to detect and acknowledge the long-term burden of this disease that we're suffering with now? Curious about scientific blind spots, data infrastructure, political pressure, all of the above.
It was all of the above. I cover it in detail in my book, as you mentioned. But just to go back to something I said earlier around how we had this assumption that the outcome of a SARS-CoV-2 infection was survival or death, not understanding that there was other outcomes, long-term disability being one of them. So we didn't have the data collection systems in place to be looking at what survival looked like. It took a little while, and groups like at the University of California, San Francisco, started looking at what survival looked like and recruiting patients. The NIH did something similar to try to understand the natural history of COVID infection. But on the political side, we had people like Boris Johnson in the UK thinking that this was a bogus condition and really dismissing patients. I think he likened it to Iraq Gulf War syndrome or something. So there was...
But can I just interrupt you?
Yeah.
Gulf War syndrome is real. It's a mitochondrial disorder.
In his mind, it was...
Right?
Yeah. But on top of that, there was also misogyny and racism and just all kinds of barriers to allowing patients to be heard and seen and understood.
So you wrote in your book about some things that are really interesting about the patient movements and then the analysis of the VA data. Can you just give us a quick insight into how some of this information finally came out?
Yeah. So, well, firstly, it was the patients themselves in a group outside of, led out of New York. Essentially, the body politic began bringing patients together to describe their symptoms. And that led to one of the first, in fact, the first formal study of long COVID. They showed something like 205 symptoms attributable to long COVID in a study that was published in a journal. And then Ziad Al-Ali, an epidemiologist at the VA health system in St. Louis, decided to try to create an experiment to look at a controlled setting and to compare people infected with SARS-CoV-2 versus people who weren't infected to see what are the longer term complications. So he was able to document illnesses throughout the body systems, the heart, the brain, the kidneys, all kinds of things. And that work was really important in showing the longer term consequences.
Now, you use the words racism and misogyny, which is, you might have noticed that because you think a virus would be an equal opportunity employer, right? But some of the work, like what Sonia is doing here, is finding that males may be more susceptible to acute COVID and females can bear the brunt of that long-term disease, whether it's long COVID, whether it's Lyme or the post-acute autoimmunity. Most autoimmune patients are women. So this is something we're trying to figure out here, that people don't fit into a one-size-fits-all model. And you also use the word racism. And there are sociological things about how, maybe if you don't have a white collar job, you can't stay at home on Zoom. But, we've always known that some people are more susceptible to diseases than others, right? Ashkenazi Jews have a higher incidence of breast cancer, No one's ever measured that. So one of the landmark studies being done here right now is the first effort to really understand what it is about genetic ancestry that makes people more susceptible or less susceptible to different disease, to actually put the name and the information on it. So the landmark study being done here by Vijay Pandurangan and Ben Schmiedel. That. History is interesting here. So COVID isn't the first thing to leave people chronically ill. So we've talked about Epstein-Barr. We've talked about 1918 flu did it. Regular influenza does it. Chikungunya virus does it. And yet the response to long COVID seemed very strangely slow and improvised. Even though we have seen this before, it's like we didn't. So what lessons had medicine already learned, and why did they not get remembered and translated faster into COVID care?
I mean, you said it yourself. We had these examples even before. We know that flu could be associated with long-term pulmonary fibrosis and other things. Chikungunya, you mentioned, is associated with a joint disease as well as other things. EBV. So I feel like we had those pieces, but what was missing was maybe synthesizing those pieces, putting them together and translating that into how does that affect clinical care? How does that affect infrastructure? Healthcare infrastructure, healthcare teaching, all those pieces, I guess, were not in place.
Well, getting back to kind of the sexism, I mean, one of the conditions that we knew about pre-pandemic is a condition called POTS, postural orthostatic tachycardia syndrome. Most people never heard of it before COVID, but now, I mean, I think, how many of you have heard of POTS? Yeah, so most people know about it. So what's interesting is it was a disease of young women. So these were typically women that would get EBV or mono, and then they would develop this phenotype where they would stand up, they would have a very elevated heart rate, they had a lot of anxiety, depression. And what happened is a lot of the medical community just labeled them as anxious, crazy women. Young women that just didn't want to work, that really didn't have an underlying biological substrate for the disease. So for many, many years, these patients, nobody wanted to take care of them. Oh, a lot of physicians would say, I don't want to take care of these POTS patients. They're just crazy. They're making it up. So that was for a lot of these conditions, because it was affecting a certain population. And I think some of it is women have more autoimmunity. They have a substrate to be predisposed to this. And so POTS before the pandemic was a predominantly female disease, didn't get a lot of attention. We weren't looking at mechanisms, and we were just dismissing it as this is lazy people, anxious women, they don't want to work, they don't want to exercise. That's kind of how it was. And so we did, because that was a disease where it had been clearly described that viruses were causing this condition. But there just wasn't research infrastructure funding invested into that population. I mean, if you look at the number of NIH grants that were given for POTS pre-COVID, I can count them on my hand. It's a very, very poor understanding. And I do think some of it was people were stereotyped. There was sexism.
Because that echoes kind of Lyme, maybe
Lyme
it
Looney.
echoes, right? Which is also predominant in women who tend to have, I mean, Erica mentioned that COVID is the perfect example in the sense that men are more susceptible, multiple epidemiological studies show that men are more susceptible to acute severe COVID because their immune system in comparison to a woman's is a little more depressed if you're looking at it relative, but women are more prone to long COVID and other autoimmune diseases because they have that enhanced immune system.
And I think a lot of people would, especially clinicians, would say, well, here's a man that got EBV or mono, and here's a woman. Well, the woman's the one that's complaining and is anxious and isn't doing anything. The man's back to work, so it has to be a psychological issue. I mean, that was what was happening.
Yeah, or even like, well, he had the more severe disease initially, so how is this working? But in fact, long COVID clinicians will tell you, especially since Omicron has emerged as one of the dominant subtypes of SARS-CoV-2, it really causes quite mild disease, and yet it's associated more with long-term long COVID. What does that tell us? We really don't understand. It's not just severe disease, long-term effects. There is something else going on with long COVID, and it's not necessarily linked to a more severe initial disease.
I wonder too whether the Omicron variant, when it emerged at the end of 2021, was also encountering pandemic fatigue, and we just really wanted to move on. I'm surprised that I'm still asked by even clinicians, medical people, whether I think long COVID is a real thing. It's true. And so I think collectively, after trauma, I think we do want to put traumatic events behind us, and I think part of us, we think it's sort of resilient to move on and try to forget the bad stuff. But unfortunately, I'm reminded of a comment that Sabrina Poirier in Quebec told me. She contracted EBV when she was a teenager and has battled with myalgic encephalomyelitis, chronic fatigue syndrome since. And she said that it's been known for a long time that whenever there is a wave of an infectious virus, there are people who are left behind. Now there are just so many people who've been left behind. We can't ignore them. But in the past, many of these people, the ME/CFS patients, have largely not got the recognition, the treatment, and hopefully cures that they deserve.
One of the most surprising and scariest things about that virus, COVID, is the nefarious effects. It's not just a respiratory virus. We're seeing effects on the heart and the brain and the lungs, the placenta, everything else. Is there something that's uniquely destructive in the case of COVID, or did the pandemic instead expose some vulnerabilities that were already there?
I think a little bit of both. I mean, I do think that SARS-CoV-2 is an unusual virus in that its tropism, what we call its target cells, are actually quite widespread. As Erica mentioned, we know COVID-19 primarily, or we knew it initially as a respiratory virus. It's like flu. But actually it's not, because flu stays in the lung. Influenza is always in the lung. Very rarely can it be detected out. Stays in the lung, respiratory illness, fine. SARS-CoV-2 is not like that. It can be detected in places, even in a patient who might be predominantly presenting as respiratory, can be detected in the GI tract, in the kidney, in the blood cells. So what does this tell us? It does, I think, inherently have the possibility to go to other organs, but it's not really well studied yet. So yes, I think there is something unique about it.
Perhaps more of a question for Sonia from me, but I wonder too, when a novel virus emerges to which humans don't have any immunity, whether that makes the immune system more likely to go into
I think so.
hyperinflammatory state
Yeah.
and cause additional
Absolutely.
collateral damage.
Especially initially. And then you mentioned Omicron, whereas, what were the subvariants and the dominant variants that are coming out are a little more asymptomatic and acute disease, but not in long COVID.
And I also think, as I've been seeing these patients over the years, I always try to understand, okay, what is it about this person that predisposed them to getting long COVID? I do think there are some underlying genetic substrates. I know you had talked about earlier that you're looking at researching that here, but I do think that there is, and we just haven't figured it out, but there's just some people that just what I call an autoimmune substrate. If you talk to them, they'll tell you in their families, they had Sjogren's, they had lupus, they had all these autoimmune conditions in their family. So I think there's just some people that are genetically just more vulnerable when they get a virus to not shut it off when you're supposed to.
The other aspect of COVID, I think, is that's worth mentioning is its role as a disease accelerant. So we saw with COVID, many patients were being newly diagnosed with diabetes.
Right.
We're seeing now more patients developing kidney failure. And we're seeing signs of neurocognitive decline, accelerating biological processes that may mean people are developing Alzheimer's disease earlier, maybe 5 years earlier. So instead of at age 80, they'll be developing at age 75. We don't know that for sure, but certainly the signs are there from the phosphorylated tau and other markers of neurodegeneration that are emerging. We need to really watch this because things like Alzheimer's disease are incurable and hugely expensive, and we're already facing an Alzheimer's and dementia crisis through population aging. So if suddenly we're burdened by an extra 10% that we weren't anticipating, it's going to really burden our health systems and families. These are really complex conditions that reverberate across society.
So I want to come to a really important point that you just brought up, which is all the other non-infectious diseases that we're seeing. So the increased incidence of diabetes is real. I remember seeing patients after having 6 months or so after having COVID infection and looking at their hemoglobin A1C, and it was maybe a little bit elevated, and then they were full-blown diabetic. And I thought, what is happening? And then we had a great study again from the VA that showed this new incident diabetes. But what's important is there's another condition where there are certain things that can happen that is associated with future adverse events, and that's pregnancy. So during pregnancy, we can have preeclampsia, we can have gestational diabetes. And what happens, or what we used to do, is we used to forget about what happened in pregnancy because it resolves after pregnancy. But what we're seeing is those women, when they get older, they get diabetes, they get more heart attacks, they just have more cardiovascular disease. So that one event is a marker. And so what we have to really do as a clinical community is when somebody has COVID, not forget about it and kind of keep thinking about it and really figure out, okay, is this person higher risk for diabetes? Is this person higher risk for Alzheimer's? And start preventative strategies, both lifestyle and certain pharmacotherapies, very early on.
So let's talk about what we don't know yet, because that uncertainty is where progress really starts. So first Sonia and then both of y'all, what are the most urgent unanswered scientific questions about these post-acute viral diseases right now?
So immediately I would think it's why. Why are folks sustaining this long-term disease ostensibly after the initial acute infection is resolved? Is it due to viral persistence? Is it due to lingering autoimmune disease or genetic substrate, as Pam mentioned? Is it due to microvascular or vascular damage or neurological damage? we have to figure out why. That's number one. Number two, I would say, is that we need biomarkers. I mean, it's tough for a patient to come in and they're frustrated because there aren't good biomarkers. Do I think that there's a be-all, end-all biomarker for all COVID, long COVID? No, I don't. But I do think there might be subtypes. And we need to find those markers so that folks can get properly diagnosed.
And the biomarker would also give people validation because they do come in with 30 different symptoms and clinicians just say, you're crazy, get out of my office. You know, and so the biomarker would be a good objective way to show that this is real, what they're experiencing.
And even if it clusters with different, you know, if neurocognitive are clustering with a separate biomarker than, for example, kidney damage or cardiovascular disease, that's okay. But that's how you put patients in different boxes so they can be treated properly.
So there's a systems question hiding under all of this. So Jason, I want to ask you to imagine a reset. So if you could redesign pandemic preparedness today, what would you change to avoid missing the next pandemic and the one we don't see?
Well, the one that we have currently is still ongoing, and so we still need to be investing in learning about this one. But I think we certainly know that we should be anticipating that the outcomes won't just be survival or death, and that we need to be monitoring and studying what survival does look like, and then hopefully preventing complications, devising strategies for managing them better when they do emerge, but just being more alert to the possibility that we will see these things.
So last question before we turn over to audience Q&A. Let's end where we began with public understanding. What should people carry forward from this experience? What's the one thing the public should unlearn about COVID? And what's one thing they need to urgently understand instead?
Not black and white. You know, the disease is not black and white. It's not that you have SARS-CoV-2 and you have COVID and then you don't, and it's not over in a sense. I think what you mentioned about, Jason, about trauma and wanting, you know, that's a human trait. You know, we persist, we move on mentally, but at the same time, we shouldn't forget the lessons. And I just don't think it's a black and white disease.
Yeah, I actually have my notes here because I feel like a bit of a rabbit in the headlights sometimes in these sort of things. But just to pick up on what you said, I want people to remember what happened, how much COVID cost us. As painful as it is to look back, if we don't take stock of what the pandemic cost us, we have no chance of doing better next time. So my book, After COVID, isn't the definitive history by any means, but it's a start, and I really hope people will read it to be reminded of how much COVID cost us.
I think I want people to learn about humility, especially in the scientific and clinical community, about how much we don't know and how important it is to invest in research, especially mechanistic, basic science research. If we really don't understand the disease, throwing billions of dollars in clinical trials, they're all going to be negative. And all of the, I'm involved in NIH Recover, all of the clinical trials have been negative, which is very sad because we've put in $1 billion into this initiative, and we really need to be putting a lot of money and infrastructure into really understanding, like what Sonia is doing, understanding what's the basic mechanism of the disease, who's more predisposed. So we need to really rethink our scientific strategy, but I think also compassion is really important because a lot of these long COVID survivors, when you look at them, they look completely normal, but they are suffering incredibly and they're dismissed. Their employers are not giving them any consideration, and they're really being told that it's all in your head. And sometimes we have to just stop and say, okay, that you did have a condition, you're suffering, let's acknowledge the suffering, and let's come up with some treatment strategies.
So now let's turn it to all of you. What questions do you have for our panelists? And do we have mic? Brooklyn's going to run a mic around. I saw one here, one there. Yep. We can start with Fred.
I just heard you say there's a lot we don't know. So maybe this is inappropriate. If I go to ChatGPT and ask about what is long COVID, will it tell me the right thing or the right things? And can you tell me, sort of, is long COVID measurable, say, by a viral load at a certain point? I presume a person has to have had regular COVID before they can get long COVID. But what's the sort of longitudinal development?
So it's a clinical diagnosis right now. We don't have a biomarker. There's not a blood test that I can do and say you have long COVID. It's really that history, like, you had the COVID infection and you just didn't recover to your functional status that you were doing before, and there's some characteristic symptoms. POTS is a very common post-COVID manifestation. We call it post-COVID POTS. About 30% of people that have long COVID have POTS. And then there's also some pretty characteristic symptoms. A lot of these patients have numbness, tingling, brain fog, fatigue. So it's that constellation of symptoms that we put together and say this is long COVID.
From the immune point of view, I wish it were that crisp, and it's not. We know that there are certain factors, immune-related factors that are emerging. For example, certain cytokines, those proteins that allow the immune system to talk to one another. IL-6 or interleukin-6 is a signature that's emerging, detectable in a lot of long COVID patients. Immune proteins called complement proteins, they tend to go up. Certain even immune cells, remember we talked about waking up, certain cells, not only do they wake up, but they multiply. So if we can measure those in the clinic, it's called the neutrophil to lymphocyte ratio, or NLR. And if that's elevated, that can suggest an immune event. In some cases, there's T cells, which are really important immune cells in the blood that do a lot of the work of fighting viruses off. T cells can be different. They can be what's called dysregulated or exhausted. So there are some emerging trends, but we don't quite have specific measurable biomarkers yet.
Down in the front in black, and then do it there.
Is the world waiting for the United States to take the lead to answer this stuff? Is it a global community? You inferred something about England. To me, what was appalling and continues politics and the science to the public is just dismal. It continues in the same vein, vaccinations, that's kind of immunity. I'm just kind of pessimistic about the whole thing. But is it a global community, or is the United States taking the lead?
I think it would be fair to say that the US did take the lead, with the NIH putting more than $1 billion into this. But other countries have stepped up, not necessarily to the same extent, but Australia, where I'm from, is studying this. I know that in Europe, there are large centers, in Germany, Charity Hospital in Berlin, for example. Many centers are trying to get ahead of this, but the US has traditionally been the major contributor of biomedical research globally. That may not always be the case, but yeah.
We hope it continues to be the case.
But the intersection between science and politics, do you call it? That was the thing that frightened me. Business.
I'm very curious about, with all the cases of long COVID, does anybody actually get better or recover from long COVID? Do you actually reach a point where the symptoms kind of peter off and you're like, maybe you're almost back to normal? And then the other question related is, does someone who has suffered acute condition, after a few years or some time, would you still develop the symptoms, all these, POTS or symptoms that could be indicative of long COVID?
So there's a wide spectrum in terms of clinical manifestations of long COVID. There's some people that just 6 months after they have some residual symptoms and they get better. And then there's some people that have very, very severe symptoms. They evolve to what I call an ME/CFS or chronic fatigue syndrome phenotype. Those are the most severe patients. These are the people that can't move. Just to brush their teeth, it's too much energy that's needed. So that's extreme, but I would say there's a significant number of people that do get better. And that's also something that we're trying to understand more, is what's the natural trajectory, and then who gets better and who doesn't. And I think some of that is also, it goes back to the basic science about, the person that gets better may have different immune system, different ways that the immune system is regulating itself versus the person that gets better. So there's a lot of people that for a short time they have symptoms. They do, especially from a cardiovascular perspective, with the heart rate, we have medicines that can control it. There is a component of deconditioning that we also work on through lifestyle strategies. So when I feel when people actually get diagnosed and get the appropriate treatment early on, they often don't progress to that very, very severe phenotype. The people that I see getting to that really severe, I can't move phenotype, have not been diagnosed, have not gotten any proper instruction on what to do. So there's a wide spectrum.
There's also another, sorry to,
No, go ahead.
before you ask your question, there's also that other category of where COVID has acted as a disease accelerant. So if you're developing Alzheimer's disease at age 70 and you were destined to get it previously at age 80, that's very difficult to know to what extent COVID was playing a role in that. We talked earlier about the data that came out from the Veterans Affairs, this one researcher in St. Louis. He was showing all kinds of additional risks that people who were infected with SARS-CoV-2 were facing 6 months later, 12 months later, 2 years later, and sometimes it was, especially early on, an increased risk for strokes and heart attacks and pulmonary embolisms and things like that. There was a very important study from the UK Biobank, which had taken brain scans of people before COVID emerged, and were able to bring patients back and then look at differences in brain scans between people who were tested positive for SARS-CoV-2 and people who hadn't. And they were able to measure essentially a decade of brain aging in 2 years. So it was a very important study because they had the baseline data that was very precious in this setting. The researcher who led that study hasn't been able to get any funding to continue to look at this patient cohort. So we're missing big gaps in our understanding, unfortunately.
So that's actually one of the gaps that was in my mind, because I absolutely appreciate what can be done from a science perspective, the importance of finding biomarkers. But what you've alluded to and what you've mentioned is the plethora of anecdotal information. And my question relates to, in what ways is anecdotal data being accumulated, collected, sorted through?
So I think initially the patient, the body politic and the patient-led research collaborative that emerged from that, these were all anecdotal accounts. So that's how they came up with 205 symptoms attributable to long COVID. So it was all anecdotal, but it was people like Ziad Al-Ali at the VA that tried to look at and compare people who tested positive versus who hadn't tested positive to see what were the health implications from that. So the anecdotes are super important because they can inform broader studies.
To follow up on that, for example, Pam, in your work and work at UCSD and other medical facilities where you are seeing in a clinical setting patients who report various things, are there systems in place to collect those anecdotes at what I'd call a primary care or specialist care at a clinical level?
I mean, in terms of capturing all of the symptoms, not necessarily, but in terms of capturing the diagnosis and offering different clinical trials to these patients, yes.
There are long COVID clinics in California. I mean, Pam mentioned Recover. That is a large multi-center clinical study for long COVID involving several hospitals. There's a very good long COVID clinic in the Cedars-Sinai Medical Center. We collaborate with them where they are capturing at least the patients in that medical center. That information is getting into their patient records.
But I also think in terms of the symptoms, I think we understand. I mean, as Jason said, I mean, there's 300 plus symptoms. The question is, what do we do about it? And really the bigger question is, what is the underlying mechanism that's causing it? And I have some theories. I think it is the immune system. I also think there's hypercoagulability, because one of the things that we saw very early on in autopsies of long COVID patients is they had microthrombi everywhere. So I think there's a lot, and there's different phenotypes. There might be one group of long COVID patients that has predominantly an immune involvement. There might be another group of long COVID patients that's more thrombotic and cardiometabolic phenotype. So I think at this point we know the symptoms. I think the next step is really understanding why and coming up with treatments.
Let's see, I see Mark, and I see in the back of Brad Greenwald over there too.
That's great.
My question has to do with the next pandemic. You've talked about what we've maybe missed on the follow-up for the COVID pandemic. Is there anything we've kind of learned that we ought to be doing more for identifying the next pandemic and how to prepare for that?
Well, we know what the families of viruses are, and we know among them which ones can spread by the respiratory route, which ones are highly infectious. And so one of the approaches we have been taking here at LGI is to look at the different families of viruses, whether they're paramyxoviruses, coronaviruses, the human herpes viruses, including the ones that cause birth defects we never get rid of, and understand how the immune system recognizes each of those families of viruses and what's successful and not successful. Because if you want to take an example of the family of paramyxoviruses, right? What the heck's a paramyxovirus? Measles, mumps, the things like avian viruses that cause $200 million a year in agricultural damage. We know what is now successful and not successful, different ways of vaccinating for those and how to reinterpret those immune responses so that we can build upon that for the next one. So the reason we could move fast for SARS-CoV-2 is because there was SARS-CoV-1 and there was MERS. And so people had already said, oh, right, how do we treat a coronavirus? What is an immune response to a coronavirus? So that's, yeah, we're prepared.
We have much better tools. Wastewater surveillance, for example.
Good.
We have the ability to create rapid tests that we can do at home. We have telehealth. We have mRNA technology for rapidly making vaccines. We have some brilliant tools. I think the societal responses where the danger zone may exist, the lack of trust in science and in vaccines and in institutions, that is a big concern for the next pandemic.
Yeah, we need to communicate, kind of like we're doing here and through your book as well. We need to communicate so that those effect tools are deployed properly.
With humility.
So I don't think this was mentioned in the discussion so far, but in the cohort of people who have long COVID, is there any difference in the people who were vaccinated or not, MRA or otherwise? For example, did the people who were vaccinated do better with long COVID or do worse? Or
That's difficult. That's a difficult question. It's an interesting question. It's a difficult to answer because most folks are vaccinated. So at this point, it's very tough. I can answer it in a different way in the sense that the surprising thing is, okay, in a patient, for example, or a group of patients that had very severe initial disease in the lungs or where have you, those folks can develop post-acute sequelae that might be linked to the extremely severe infection that they experienced weeks or months ago. the most quote unquote interesting and maybe puzzling population are those that, again, there's a whole, and we know this because we collaborate with the Cedars-Sinai Long COVID Clinic, and they very smartly enrolled healthcare workers very quickly, because those folks have to get tested because they're working in the hospital. And what that meant was that identified patients, healthcare worker patients, who were infected but had no symptoms. And those folks are developing long COVID, but they were completely asymptomatic, often vaccinated, or maybe they had Omicron. And so I guess what that tells us is that, yeah, I think vaccination always helps, by the way, because you're not fighting two things. You're not fighting that awful severe infection. There's damage there. But certainly I would say that there are a subset of patients that had very mild, quote unquote, disease, but still developed long COVID. It's puzzling.
See Brad, and then there are a cluster back there.
Is it possible that we essentially all have long COVID? It's just a matter of what degree. And another way to sort of frame that is, let's say I don't feel like I have long COVID. I did have COVID. I don't feel like I have long COVID. Am I as healthy as I am? Am I healthy now as I was 5 years ago or 6 years ago?
So rarely do we deliberately infect people with a virus and kind of see what happens. But the UK did run a human challenge study where they had people early in the pandemic, younger, healthy adults who volunteered after lots of ethics approvals. But these volunteers had never experienced SARS-CoV-2 before, and they were challenged with the virus. So not all of them were infected by that challenge, which is interesting. Some of them had an aborted infection, so never actually developed a proper infection. But the ones who developed an infection, before they were put into this experiment, they were asked to do some cognitive tests. And a year after they repeated these cognitive tests, it was a battery of tests, and it was discovered that the ones who were infected performed worse on the cognitive tests. And the scientists who conducted that experiment told me that it was equivalent to about a 6 IQ point deficit. So a tad dumber, if you like, a year later. And none of them developed like severe reaction. They were all like mildly infected. And none of them said that they experienced long COVID. So I think, to answer your question, I don't think we really know, but that human challenge study is certainly interesting.
It's very fascinating, because you do wonder, especially in our older patients, what's so a lot of things are attributed to natural aging, or patients come in and say it's that statin or this other drug that you gave me. So, I mean, it's very intriguing, that data.
Hi, a question. I'm back here. I may have missed it. What's the data on persistence of the virus, however you would look for it, PCR or whatever, in the long COVID individuals? Is that data been looked at?
Yes, by multiple groups. One study that came out early in the pandemic, which I found personally fascinating, was led by an NIH researcher who worked on Ebola and was familiar with the long-term consequences of Ebola. And we know that with Ebola, people can remain infectious for a long time. It can get into the immune privileged sites in your eye and in your testis, and you can actually still transmit Ebola much later through seminal fluid, for example. So this researcher, Dan Chertow, thought we really should find out where this virus is going in the body of people who experience COVID. So he led a study, a very detailed autopsy study of people who died from COVID, 40 patients, and they tested them incredibly thoroughly. I think they collected hundreds and hundreds of biospecimens from each patient. It was like more than 10,000 biospecimens in total. And they were able to document the virus throughout the body and brain of people who died from COVID. that didn't mean that they had long COVID or that the presence of the virus was what is linked to long COVID. But researchers, for example, at UCSF in San Francisco are doing that research. They are taking biopsies of gut tissue in the lymph tissue and certainly seeing evidence of SARS-CoV-2 persistence in the GI tract. There is also really interesting work underway in San Francisco with the medical examiner that relates to a long-term study of sudden cardiac death, when people have suddenly died and they've have this diagnosis. The medical examiner has done detailed autopsies to figure out what exactly patients have died from. A collaborator, Zian Zhang, a cardiologist in San Francisco, is now working to understand if these patients also have SARS-CoV-2 in their bodies when they die, and they certainly are finding it, and they are finding it in the brain, which is interesting.
But one of the puzzling kind of counters to that, and that is, I think, super, super intriguing, is the failure of the clinical trials. So Paxlovid, which is an antiviral drug, which would be expected to tamp down that virus in any other organ, Paxlovid has failed thus far, and I do say that, in clinical trials for long COVID. And that's a real disappointment, because a lot of folks expected the Paxlovid antiviral, it's gonna take, it's gonna make long COVID better. But it hasn't. But there's still some questions there about how early it started
Linda, and then there's two back there. No?
With patients who may have hyperimmune systems developing long COVID. Is there any correlation between status of the immune system with age? I mean, are there fewer long COVID patients who are elderly?
I would think it would actually be the opposite, because it is true that as we age, our immune system ages as well. But that doesn't necessarily mean it's off all the time. What that generally means is that it's not on at the right time and on at the wrong time. So it's more dysregulated. An aging immune system, for many factors, can be more dysregulated. It's not on point. It's not, as we say, sleeping when it should sleep and awake when it should. So I think it's actually the opposite, where age is likely going to be, as it is associated with increased incidence of Alzheimer's, for example, other neurocog diseases, and cardiovascular and neurovascular dysfunction, that it might be more of an age-related exacerbation as opposed to being the opposite.
Because of the lateness of the hour, I think we'd better stop there and move the discussion to the reception in the middle. So first, I want to thank our panelists for a thoughtful and illuminating discussion. I'd like to thank all of you for joining us tonight. I think one of the things we learned is that the things that we need to understand don't just arise during the acute crisis itself, but in the long period of discovery that follows. And that is exactly the work that we here are committed to do. The scientific rigor, the curiosity, and the collaboration to answer some of these things and come up with some of these immune mechanisms. So I'd like to invite you to join us at a reception out in the center, where Jason can also sign some copies of his book. And I wish you all a very pleasant evening.